Hi, we're going to talk about now the drug therapy for migraine in this particular lecture. I'm Dr. Deepika Tikku and I'm MD Pharmacology. So let's start for what are the important points you should remember about this therapy, about the drugs for migraine, especially for when we start in the second year MBBS. And definitely this can be taken forward. So, first, what are the various important features of migraine? There is a pulsating headache. And pulsating headache, I mean कि अगर आप अपनी pulse check करो, you can feel the pulses throbbing like this. So you can, when you touch the head, the patient can feel the same thing. It's like pulsating, right? And no, he gives you a classic example या classic उसको जो बताता है आपको जैसे हथौड़ा मार रहा है कोई मेरे सर पे. That's the kind of pain he feels. And it's usually on one side, unilateral, and it comes in attacks. So the attack can last for few hours. Attack can last for 2 or 3 days itself. So mostly जो उसमें time होता है from 2 to 48 hours to even to 72 hours in some people. So it comes in attacks and then it will go. कईयों में ज़्यादा frequently आता है, कईयों में कम frequently आता है, depending on the type of migraine. Then it is associated with lot of nausea, lot of vomiting. And आपको वैसे भी you feel that जब भी किसी को बहुत pain होती है तो ये nausea, vomiting एक normal feature है जो pain के साथ हमेशा आता ही आता है. And that is because of sensitivity to the light and sound. And what happens actually जो migraine है, it gets triggered. Trigger कैसे होता है, किसी को attack आता कैसे है migraine का? That is because of certain things which are very जैसे लाइट बहुत ज़्यादा पड़ रही है, सो वी डोंट लाइक वेरी ब्राइट लाइट, सो वो पेशेंट ज़्यादा सेंसिटिव होते हैं, सो दे हैव द माइग्रेन अटैक. साउंड बहुत ज़्यादा है, यू गॉन टू अ पार्टी और धम 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 म्यूजिक इज ऑन, और यू आर सिटिंग एट योर होम, योर नेबर्स हैव पुट ऑन सम लाउड म्यूजिक एंड दैट विल गिव यू माइग्रेन अटैक. ठीक है, सो यू गॉन समवेयर, यूर इन ट्रैफिक, बड़ी ब्राइट लाइट आप पे पड़ रही है, दैट गिव्स राइज टू अटैक ऑफ अ माइग्रेन. So these can be various triggers which actually set migraine into action. So that is what. And patient ऐसे में क्या करेगा, patient would want to avoid all these things. So obviously किसी को इससे ऐसे अटैक हो रहा है, so patient सबसे पहले क्या करेगा, patient will go into a room, switch off all the lights, be in the dark, because that is what gives him relief. He will not talk to anybody. You will see these patients, they just want to go get into a dark room, eyes closed, quietly. Because if अगर वो physical activity करेंगे तो attack will go on increasing. So they have to take rest. If you do physical activity, because sometimes हमें normal mild headache होता है, हम सोचते हैं कि अगर हम कोई काम कर लें, our mind will be diverted and we can now go and do our work. But इस केस में नहीं. इस केस में क्या होता है, if you actually try and do some physical work, attack this pain would be actually more aggravated. So they have to take rest in this case. So gender wise देखा जाए तो females are more prone to attack as compared to males. Types of migraine, if I have to talk about the types of migraine, see there are two types. One is your migraine with aura and migraine without aura. Aura क्या होता है, aura is something that happens before the actual headache starts, ठीक है, the attack starts. So some patients में क्या होता है, visual aura आता है. So visually they can see certain lights, or they see something. Auditory कुछ हो रहा है, कुछ सुनता है. Tactile aura है, कुछ feel हो रहा है. So that is your aura, and something they sense before it. And this is called as your classical migraine, but this is rare. This is not a common type of migraine. The common type of migraine जो maximum लोगों में होता है, that is without aura. That's why इसको हम common migraine कहते हैं. So there are no these कोई perceive, कोई aura वगैरह कुछ नहीं है इसमें. And I told you it's aggravated by physical work, and it is aggravated by if you further continue patient को उसमें exposed रखोगे, light में, sound में, patient is going to have an attack. So this is what aggravates it. So two types of migraine, and without aura one is more common. Let's come to the pathophysiology of migraine, which actually is more important, because if you understand the pathophysiology, you understand the drugs, and when you understand the drugs, there is no need to mug up the drugs. It is very, very clear when you understand the pathophysiology. So to start talking about the pathophysiology, there are certain areas where still हमें पता नहीं है why actually these things are happening, right? So the trigger, how does the trigger actually sensitize those nociceptors in the brain, we still don't know, but we are still figuring out कि कैसे हो रहा है. But जो हमें पता है, let's do that. So this is your central nervous system here, ठीक है, this is your CNS, and जो ये pink में है, these are your in your brain में meninges हैं, your dura mater etc. सारे meningeal coverings हैं, and in that you have your nociceptors. So this nociceptor, if you want to talk about, this nociceptor, it gets aggravated whenever there is an exposure to that trigger जिसकी वजह से migraine हो रहा है. And when it gets sensitive, how it gets stimulated, that is only the query. So whatever, it is getting now stimulated, and it has got vesicles which contain certain chemicals here like VIP, vasoactive intestinal peptide. It has substance P here, and one of the most important is CGRP. So all these are going to be released. Calcitonin, gene related peptide, substance P, VIP, all of them इकट्ठे. Now they are going to march out. ठीक है, मौका मिल गया इनको बाहर आने का. So now they are coming out. So what happens now? What they do? Migraine कर, अब पेन कैसे होगी? पेन तक पहुंचना है ना हमें. So let's see ये पेन तक कैसे पहुंचाते हैं हमें. Chemicals release हो गए, अब क्या करेंगे? There are two things what they can do. First, they will go एक indirect तरीके से. इन्होंने एक तरीके से काम नहीं करना, दो तरीके से काम करना है. पहला तरीका, they are going to stimulate your mast cells. So they want to carry an army with them. अकेले इनसे काम नहीं हो रहा, और बंदे इकट्ठे करना चाहते हैं. So they are going to carry an army with them. So they are going to knock on the mast cells. Knock, knock. Come on, get out. Be in action. और mast cells के अंदर कौन बैठे हैं ये green green? That is your histamine mainly. So histamine को भी बाहर ले लिया इन्होंने. So now कितने लोग हो गए? VIP, substance P, CGRP, histamine. So अभी इतने सारे लोग हो गए. So they are going to now produce the effect. So what does histamine do basically? Histamine will act on the blood vessels. These are your cerebral blood vessels. And what does histamine do? What is it known to do? It causes vasodilatation. So yes, it is going to lead to vasodilatation. And vasodilatation में क्या होता है? Your vessels are stretched, right? So vessels are stretched. Vessels are stretched this way. Vessels are stretched this way. They are stretched like that, right? So there is going to be some space created between the endothelium. अब जो अंदर हमारा इतना प्लाज्मा एंड एवरीथिंग है, पहले there was no space, ठीक है, रास्ते बंद थे, दरवाज़ा बंद था, they couldn't go out. Now दरवाज़ों में लीक आ गया है, ठीक है, दरवाजे खुल गए हैं थोड़े से. So all this plasma is going to now come out. And this is because of vasodilatation it's causing this. So there is going to be an increase in the vascular permeability that we call. Vascular permeability. That's what we have. So vasodilatation के साथ ये इतना सारा plasma is now out. And when so much thing is out, what it does is, it is going to now irritate these other nerves. And ये क्या हैं? These are your cranial nerve 5, which are your trigeminal nerve endings. These are your trigeminal nerve endings. They are going to get sensitized. They will pick up the inflammation होगी ना because of this. क्या हो गया यहाँ पे? जब इतना fluid बाहर आ गया, so what is happening here basically? Happening here ये है कि यहाँ पे inflammation होगी. Neurogenic inflammation has taken place. And that inflammation mediators or release होंगे. They are sensed by this trigeminal nerve endings. Let's stop here. अभी हमने इन्होंने ये indirect काम किया था VIP, SP, CGRP by secreting ये histamine को बाहर निकालने का. अब खुद से क्या करते हैं? They also have the same function. ये खुद से भी vasodilators हैं. So ये double काम कर रहे हैं. खुद से भी vasodilatation they are doing, and they're also taking the help of histamine. So definitely when they're taking the help of histamine and they're doing the work themselves, they are causing increase in the vasodilatation and they're going to cause inflammation. And this is sensed by now your trigeminal nerve endings. So when these are sensing it, they carry this message to your cortex, okay? And they carry this message to the cortex that there is some inflammation going on, and that what is happening is now ये जो sensory areas हैं वो the trigeminal जहाँ पे करता है, what it does is ये सारा area it is the sensory है ना, so जहाँ पे supply है, so in all these areas the patient starts feeling pain. ठीक है, that is the major thing. So patient starts feeling pain because of this. Now this is what the throbbing pain is all about. So basically what are we actually looking at here? If we talk about here, the important thing here to note is that this vasodilatation led to increase in the vascular permeability, ultimately led to inflammation, and then it led to the pain. ठीक है, and ये start कैसे हुआ? When this was released. So if we stop the process at any point, that can lead to decrease in the pain. So that is the treatment all about. So ये pathogenesis starting from the release of these chemical mediators causing vasodilatation, vascular permeability, inflammation and pain. Any point we stop, we give the patient a relief by giving the drugs. So जो भी हम drugs करेंगे, they are going to actually target any of these things. Other important thing to remember here is what I've drawn, the 5-HT receptors here. जो 5-HT receptors हैं, they are present here. They are presynaptic receptors, and they're also present on the cerebral, the cranial blood vessels. So what is the role of 5-HT basically? So when you give a 5-HT agonist here, they are going, when presynaptic receptors, they get stimulated, they are going to cause decrease in the release of these mediators. So that is number one. If you give an agonist, there will be decrease in the release of mediators, so decrease in the process which happens further. The other two, our second thing which does it, when you give a 5-HT agonist here, they are responsible for causing your vasoconstriction. 5-HT causes vasoconstriction. Serotonin causes vasoconstriction. Remember that. So whenever you try to improve the level of serotonin by giving 5-HT here, they are going to cause vasoconstriction. So whenever a 5-HT agonist hai, that causes vasoconstriction. So decrease in the inflammation bhi ho sakta hai, and the vasoconstriction. That's the role of 5-HT1 agonists. What is their role? Because they can decrease inflammation as well as they can cause vasoconstriction, which is opposite of vasodilatation. That you should remember, right? Now, coming to your drugs for migraine, we have two types. When attack ho raha hai jab patient is having an attack, acute attack of migraine, you give drugs for that. And once the attack is over, you give drugs which are going to prevent any further attack. And prophylaxis, is usually given to those people who have frequent attacks. Okay? Those who have frequent attacks, so maybe around 2 to 3, more than 2 to 3 per month. So in those people we give severe migraine hai, there we give prophylaxis, moderate to severe migraine. For mild attacks, jo once in few months ho raha hai, there you don't need to give any prophylactic therapy. Why do you want to give drugs unnecessarily over there? So let's go for drugs with acute attack. Now इसमें क्या ज़रूरी है? Some people don't have बहुत ज़्यादा problem नहीं है उनको, and you initially start with giving simple painkiller, simple analgesics like NSAIDs. आप NSAIDs दे दोगे और अगर vomiting है, because you can give some antiemetic like metoclopramide, you give a promethazine, patient is going to be fine, and then you don't need to give any other drug. It's only when mild migraine में ये sufficient रहता है, we don't have to actually give anything else. But yes, if the pain is severe and or it's even moderate in nature and the patient doesn't get controlled by these, then you have to resort to other drugs which are called as your triptans and then the ergot alkaloids. Triptans by far, currently they are the drug of choice for moderate migraines as to severe migraines. And if for some reason you cannot give a triptan, then you go on with the ergot alkaloids. So coming to your triptans fast, what are the triptans going to do? Basically, they are going to, I told you, they are agonist at 5-HT1 DB receptors. So they are going to decrease the release of the inflammatory mediators. So they are going to ultimately decrease your neurogenic inflammation, because ना CGRP release हुआ, ना vasoactive वाला release हुआ, ये वाला सारा step. So no CGRP etc., no substance P, and no VIP. So they are going to decrease the inflammation. The second area where they're going to act is here, 5-HT. And you know what they cause? 5-H stimulation. So there is vasoconstriction, because vasodilatation is occurring in migraine and you require a vasoconstricting here. So that's their major mechanism of action. And the drugs we have, all of them have triptans at the end. There's no other group of drug in pharmacology which has a triptan at the end. So jahan bhi triptan aata hai, that becomes your drugs for migraine. So sumatriptan, naratriptan, rizatriptan, zolmitriptan, alotriptan. So out of this, your sumatriptan hai, S for suma and S for short. It is a very short acting drug. So जो short acting drugs होती हैं, problem with this drug is that actually एक बार इनका action खत्म हो गया, so there is a rebound headache. Patient में rebound headache के chances बढ़ जाते हैं. So we don't now give sumatriptan as much. We have other drugs. Rizact is a trade name for a drug, rizatriptan. It's one of the fastest acting. Fast. All of them can be given by oral route. Very important, because that's the best thing possible. It can be taken orally. Oral route से दे सकते हैं. ठीक है. And naratriptan, they can even be given by N for nasal and for intranasal route. So rizatriptan is the fastest acting. It is quite preferred, the fastest acting है, and within 2 hours patient को relief आ जाता है. That is the best thing about these triptans. They don't have any problem of nausea. उन कुछ भी नहीं करते. They are very good, very beneficial to the patient. So we prefer to give. But sumatriptan, remember, we don't give because of the problem of rebound headache, being a very short acting drug. ठीक है. So अब जो ये vasoconstriction cause करती हैं, ये सिर्फ cerebral vessels में नहीं, ये पूरी body में और भी जगह पे they will cause vasoconstriction. So because of that thing, the problem is it can cause vasoconstriction of the coronary heart में vessels में भी vasoconstriction cause कर सकती हैं, and other vessels में throughout the body. So basically in heart में जो problem कर सकती हैं, so we cannot give it in patients who already have some ischemic heart disease, because it can precipitate angina, myocardial infarction in those patients. We cannot give them. So patient की history लेना बहुत ज़रूरी है. अगर उनको ऐसा कोई problem है, we don't give it. Then obviously because they are vasoconstrictors, we cannot give them patients who are suffering from hypertension. Third thing to remember, never ever give them with ergotamine together. So let's say patient को triptans नहीं suit कर रहे, they are not actually benefiting from triptans. We want to shift them to ergot drugs. So you should give a gap of 24 hours before you give the ergotamine or the other drugs of ergot alkaloids, because both of them are going to cause dangerous vasoconstriction. So that can be really, really a problem in that patient. So always remember, at least a gap of 24 hours should be given between these two drugs, right? That was about the triptans. That is all about triptans that you should know. The second group, if let's say triptans are not being, tolerated or nahi farak pad raha, then we go on to ergot alkaloids. So they are not preferred for a reason. I'll tell you the reason. See, what is ergot alkaloid? They are actually a fungus. You can see the black structure on the corp. It's a fungus like claviceps grows on crops. And crop यहाँ पे राई है. Or if somebody consumes this fungus wala crop, and they can get ergot poisoning also. Now, ergots, pehle hum actions pe aate hain. They are powerful vasoconstrictors. Powerful vasoconstrictors. Better more than even the triptans. Why? See, one, they have the effect on 5-HT1, just like sumatriptan or triptans. But they also have an effect of the alpha-1. And alpha-1 आपको पता है, they cause vasoconstriction. So they have double effect. ठीक है, so they are very, you have to use them very, very carefully. So definitely, hypertension नहीं देंगे. IHT suspected भी है, नहीं देंगे. The third area is in pregnancy. Never. Contraindicated because the uterine contractions शुरू कर देगा and leads to miscarriages. It has even led to convulsions in patients. Gangrene is it's a common thing. अगर long term इसको दिया जाए. So side effects की बात करें, so definitely it can lead to gangrene. If you go it high dose दे दिया and long time के लिए दे दिया, it can lead to miscarriage. If you are giving it to a pregnant female, then it can cause convulsions also. So again, never give them to these patients who already have some cardiac issue, hypertension, and any of these reason. And 24 hours for gap, we know that you have to put it in between the triptans. They're also given, along with caffeine. Caffeine भी preparations आती है market में जहाँ पर caffeine साथ में होता है. The role of caffeine basically is that they increase the absorption of ergot alkaloids. So that is one thing that is present. ठीक है. Types, we have different types of ergot. We have naturally occurring है, like we have ergotamine. ठीक है. We have ergotoxin, etc. ठीक है. और इसी को सिंथेटिक फॉर्म में क्या इसका डाईहाइड्रो डेरिवेटिव बना के जो हम यूज करते हैं ज़्यादातर, इट इज डाईहाइड्रो ergotamine, and this is used for migraine, not ergotamine, because इसमें जो alpha 1 property है, 1 action, it is comparatively less. It doesn't have, so it is safer. So dihydroergotamine is used as a second choice in case of migraine. Coming to the prophylaxis, as I told you already, prophylaxis is only given to those where the this is moderate to severe. Mild cases mein we do not need prophylactic therapy. And if you remember the ABCD of therapy here, prophylaxis ke liye, what drugs are given for prophylaxis? With A we have your anticonvulsants, antiepileptics or anticonvulsants like valproic acid. We have lamotrigine and we have topiramate. ठीक है. And the reason why they can be effective as drug treatment migraine, because they, what they do, they are going to inhibit the sodium channel blockers. So they will decrease the action potential. So, the sensitivity in the trigeminal nerve, the action potentials come honge, and the message in the nerve is carried via action potentials. So that can be stopped. So they can be used for prophylaxis of migraine. The second one is B. B से हमारे पास 2 drugs हैं. One is your older option, and जो preferred है actually, it's a beta blocker. Beta blocker like propranolol. And why propranolol beta blockers are used? That beta 2 receptors, they lead to vasodilatation. So if you give a beta blocker, it will be vasoconstriction. So it is going to help these people. The second one is your botulinum toxin. Botox, ever heard for Botox for migraine? It's there. So botulinum toxin, expensive therapy है. You give injections on these, the areas जहाँ पे trigeminal nerves की है innervation. So botulinum toxin is given. So you give an injection, Botox injection every 3 months. ठीक है. So इसमें क्या कब देते हैं, कौन से patients को? Usually we try all the other drugs. If they are not really proving effective, then especially the patient की attack frequency more than 15 per month attacks है, इतने attacks हो रहे हैं, prophylaxis, the other drugs are not doing any good, then you give for this because expensive है, and it's a newer therapy. Ona botulinum एक के नाम से है, and अभी बहुत ज़्यादा इसके साइड इफ़ेक्ट्स वी डोंट नो. जो बाकी नोन साइड इफ़ेक्ट्स है पता है, बोटॉक्स के, ड्रूपिंग ऑफ द आईलिड्स एंड ऑल, दैट इज़ देयर. But whether there are other associated side effects, we'll come to know once we have a longer data or larger data. So these are it's very new, so it's an important one, botulinum toxin. Then C say we have your calcium channel blockers like flunarizine, even verapamil, they decrease the entry of the calcium ions, and that has maybe that's associated with the hypoxia and all created initially. Okay, so that's they decrease the calcium ions. D say actually it is your antidepressants, which is your tricyclic antidepressant, TCAs. That is the D, and in this we have Amitriptyline. Amitriptyline, which is given at bedtime. And what should they be doing? Actually, what they do is they are decreasing the reuptake of 5-HT. ठीक है, ये reuptake ये pre synaptic terminal है, ये post synaptic terminal है. जब 5-HT रिलीज होता है, क्या होता है, इसके ट्रांसपोर्टर्स जो होते हैं जो उसको वापस ले जाते हैं 5-HT को. ठीक है, इन द प्री साइनेप्टिक टर्मिनल. सो 5-HT डेफिनेटली जब वापस चला जाएगा तो यहाँ पे लेवल्स क्या हो जाएंगे इसके, कम. एंड वी सी हियर वी नीड 5-HT. व्हाई? बिकॉज इट विल कॉज वेजोकंस्ट्रिक्शन. ठीक है, सो वी नीड टू हैव गुड अमाउंट ऑफ 5-HT विद अस. सो वी गिव tricyclic antidepressants, which when you give prophylactically, it will make sure that 5-HT के levels कम नहीं हों body में, especially. और अगर ऐसे patients they are also depressed, because you know कि migraine is very crippling for the patient. Patient may go into depression because of that. तो अगर patient is already depressed because of this, then this is a very good option. So you give tricyclic antidepressants. It will do the work of antidepressant. It will also do the work of being a drug for migraine. So you should give it at bedtime. That's the best time to give these drugs. And actually, you know, the interesting fact is कि इसको दिया तो patients को गया था for depression, but it was found that migraine जिनको था उनके attacks भी कम हो गए. Similar is the story with beta blockers. Propranolol was given to patients of, it's given for heart failures and angina में. तो दिस वॉज अ चांस डिस्कवरी कि जिन पेशेंट्स को माइग्रेन था अलॉन्ग विद दोज अदर डिजीजेस, दे ऑल्सो बेनिफिटेड फ्रॉम दिस ड्रग. सो बेसिकली दिस स्टार्टेड ऑफ एज एन ऑफ लेबल यूज़. मतलब इट वॉज नॉट ऑफ लेबल यूज़ होता है कि व्हेन जिसके लिए आपको परमिशन नहीं मिली होती है FDA से. ठीक है, बट आप परमिशन जिस चीज़ की मिलती है दैट इज़ द डायरेक्ट यूज़ जिसको हम कहते हैं. बट ऑफ लेबल है कि इट्स नॉट, you have seen, yes, this can do good in this patient, this particular disease, but isko approval nahi mili hai for that particular indication. That's an off-label drug. Yes, so with this we come to the end of the drugs for migraine. So I hope I'm clear. Like pathophysiology, remember that it is your chemical, the elements are there, jo chemicals hain sare, they are creating vasodilatation, inflammation, triggering your trigeminal nerve, and trigeminal nerve jahan supply karti hai, the area gives pain. So you have to कहीं पे भी you have to decrease now the chances of that कि कहाँ पे हम decrease कर सके. So if you remember here that what we have done, let's see here. So we have tried to give 5-HT1 here यहाँ पे. ठीक है, so I guess this no, ये 5-HT1 agonist दे सकते हैं. So they decrease this particular inflammation, and then they will also do vasoconstriction. That is what we are doing in most of the cases, right? So किसी ना किसी तरीके से हम अगर हम डायरेक्टली इन्फ्लेमेशन को ही कम करना है, सो यू हैव योर ड्रग्स लाइक NSAIDs एक्सेट्रा. एंड अगर MSS को वॉमिटिंग को कम करना है, गिव एंटीमेटिक. सो दिस इज द ड्रग्स फॉर acute attack. And prophylaxis will remember the ABCD of therapy, and that is going to prevent any further attack with migraine. So with this we come to the end of this particular video. So if you like such videos, please subscribe, give us a thumbs up, and please leave a good comment. Thank you so much.